Very warm welcome to everyone. We are from HART Fertility Clinic. We're based at the world-renowned Christian Barnard Hospital in Cape Town's foreshore. We're a full-service fertility clinic offering all treatments from artificial insemination to IVF and egg donation and sperm donation. In this installment of HART's Fertility Diaries, we'll be chatting to Jeanne Freed, who is HART's clinical social worker. Jeanne has over 20 years of experience working therapeutically with adults, adolescents, groups, and organizations. Welcome, Jeanne.
Thank you. Thanks for having me.
Can you let our viewers know a little more about yourself, please?
Yes, thanks. So I am a clinical social worker, currently in private practice. I have worked, for the last 20 years in various different settings, be it schools, tertiary education settings, mental health clinics, and of course in the fertility field. And currently I'm in private practice, and I see adolescents and adults for a range of different issues, as well, of course, my involvement with HART and in the field of infertility.
Okay, thank you. Can you tell us a little bit more about the day in the life of a social worker?
Yeah, look, I suppose social workers, can do various different types of work. So, social worker can take different shapes and forms. In my particular area as a private practitioner, my day spent consulting and seeing clients for a range of different issues, whether it's around life changes, whether it's around trauma, loss, parenting issues. I do a lot of work with families, which I suppose links to my work in the fertility area, because it's about families and systems. So I find that connection it was an easy connection to make. For many years I worked in a school setting as a school counselor. So, working with, and in a school setting, it's a community that's often reflective of a range of different issues. You kind of see it all in a school. Families who, have families in many different ways and shapes and forms. So a lot of my work is with parents and children so my days spent consulting and working not only with my clients, but also working within teams, which is always the enriching part of the work and the helpful part of the work. So most often, some clients, and especially families, might be involved in working with other practitioners, whether it be psychiatrists, educational psychologists, schools. So some of my days spent consulting with other professionals as well.
Okay. And how long have you been working with HART and EDSA?
I would say about 6 or 7 years already. I became involved. I had experience with, in the past, knowing other clients and knowing family and friends who, experienced infertility, but officially started working in the field and the area with HART, I would say 2015, 2016.
Okay. And you screen our egg and sperm donors. What do you think motivates women to donate their eggs?
Right, women and men actually. So, there are often a range of different reasons, but if I unpack over the years of my work with donors and I look at the main themes, so I suppose one could, divide it up into altruistic reasons, and which there are often, and then also financial reasons, and often there's a mixture. So a lot of people will often say, sometimes in the past they've been blood donors, and their whole aim is to try and help and assist where they can, give families and parents an opportunity to have children where they wouldn't be in a position to. So to really kind of give out and give back to the community and give back. Some have had experiences in their own families where aunts, uncles, cousins, sisters, siblings have struggled to conceive. So they've had direct personal experience with people, and it alerted them. and some, those are some of the reasons. Some people would say they watched a movie and they saw this and it drew their attention to it, and they Googled and this is what they come. Some people have had friends who have donated and shared with them, and therefore that's how they've heard about it and alerted them to the need out there. Yes, and then some people do it for financial reasons, and I'll talk more in my assessment. I'm sure you're going to ask me about my assessment and what so it's just ensuring that for whatever reason it is, that donors have thought through, because that's a big part of my session with them, is assessing their motivation and talking through that those have been carefully considered.
So what is covered in a full psychological assessment for a potential donor?
Yes, okay. So a full psychosocial assessment includes, well, firstly, I will talk about that, but also I suppose the main purpose of my assessment is to gain a psychosocial history, which I'll tell you what that's included, but also, of course, to speak about motivation, readiness, and for them to think through implications for themselves in various areas. And of course, to make sure they're not being coerced and this is of their own free choice. Also, to determine reactions if they finding out that it's been a failed, just to manage expectations. Yes. However, the full psychosocial history. So I usually gain an in-depth history about the client themselves and their immediate family and grandparents. And with regards to that, specifically with the client, a marital, sexual, and reproductive history. Also their current relationship status and stability. And I think that's quite important to understand where, for me, it's part of the exclusion criteria too, but where the person is currently as well. So that we know what their current mental frame of mind and state is, that they are able to make this decision that they are not, there's nothing standing in their way of making a thoughtful, carefully thought out, rational decision for themselves with regards to this. So, so a lot of the questioning is about where they're at right now and who their support system is. Also family and educational background. I assess for if there are any specific learning difficulties or challenges that would not be a reason for exclusion. However, I do determine that because sometimes there can be genetic conditions which would therefore then be shared. It would be relevant information, for a recipient to be able to make an informed choice. So personal and family history. So, another very important part, which also again links to the exclusion criteria, is the psychological mental health history and background. Have there been any psychological and major personality disorders being diagnosed for the donor themselves and their immediate family and grandparents? Specifically look at bipolar and schizophrenia because there's a high rate of genetic passing down of that, and I also take an in-depth substance abuse or substance use abuse history, family members, to determine that, because that also links to exclusion criteria, which we'll discuss later. Abuse and neglect, criminal record. I also look at current use of psychotropic medication, because that also informs and helps me to understand mental health background and history, but also implications for treatment for the donors. Okay, stress and coping skills, and that's very important also, because I need to also know and then be able to pass information back to the clinic how the donor might cope with the treatment process and the expectations. As I said already, past current substance use, their social support network, parenting relationships with existing children, and any religious or cultural influences that might also impact, and that also helps them to just consider their decision and the impact that it might have. Yes. Is that clear?
Yes.
I've covered most of it, yeah.
Yes. And Jenny, what is the main criteria that would exclude a donor from the egg donation, sperm donation process?
Yeah. So, the main criteria would be, if there was a present, treated or untreated specific psychopathology or mental health diagnosis of a mental illness. Now, most usually, as I said to you earlier, schizophrenia, bipolar does immediately exclude a donor, and if it's in the immediate family. if there is depression or anxiety, that does not immediately exclude a donor. It does, of course, depend the extent and how many family members, and if the donor is currently, experiencing symptoms, I would need to assess that in terms of her current mental state. So that goes on to the next reason for exclusion, is if the donor is currently experiencing any significant psychosocial distress, that would be impacting on their ability to tolerate, manage, and make the decision around the donation, if that's clear. Also, obviously, if there's evidence of coercion, that the person's not doing it of their own free will, current substance abuse, and a significant history of substance abuse in the family. And of course, then if there is, a certain amount of restrictions on donations based on age or number of previous donations. But Kenny, you usually would assess that before. That usually wouldn't come to me. Yes, as I said, a family history of diagnosable psychiatric conditions and unresolved or current legal issues that are pending that would have implications on the donation process as well.
Okay, and from your point of view, Jenny, why is a assessment or a session so important for a donor?
Yeah, I just think.
Sorry, maybe I should put it another way. What does a donor benefit from having a session with you?
Most often the donors actually find, I'm saying not always, but most often, they usually find the session quite cathartic, therapeutic, and helpful. Anyway, just to reflect, and I do warn donors when they come in, I do ask personal questions. It can be evocative and triggering. And I try and do it in the, very supportive way, and important they know, have some preparation around it, but it most often is used as an opportunity for reflection and looking at oneself. And, most often people usually go, this is very helpful and useful. Sometimes it's even identified when a donor might need extra further support, and then I can refer them on. So if there's something needs to be identified, it's an opportunity for that.
Okay.
It's always like that. Sometimes it can be triggering and hard, and then I try to offer support through that process as well. But then one could also think that it was an opportunity to identify. But why do I think it's important for the donation process? Certainly that donors are given an opportunity to carefully consider all the implications. Most of them have thought through this. I always check, another thing I always check in my session with them, have they discussed this with anyone else? So where I know this is a private choice and that's fair enough, it is often useful that they've spoken to one or two other people, because it's sometimes through talking about it that they can get other thoughts and perceptions about it, which can help to examine their own opinions and then make sure that they're sort of okay with it. So I think that it provides them an opportunity to think through. I offer, kind of share implications. Have they thought through this? Are they comfortable with it? So in many ways, this assessment for me is also for the donor. It's not only just about getting information from them. It's to make sure they are really okay with what they're doing and that they've been given the opportunity to think through this. Okay. And again, earlier, as I said to Kenny, like if there is any thing that we need to know around anxiety, depression, that the medication for the fertility treatment might trigger, might not, but then we know about it and we can be prepared to support.
All right. What sort of advice do you offer, or would you offer recipients who are looking for their perfect egg donor?
Not an easy one, right? I think that when a recipient gets to that point, after a long process and hard and difficult process, there can be feelings of loss, there can be feelings of being out of control, not being able to use one's own gametes. And so importantly, I suppose, helping the recipient to just acknowledge and deal with those feelings of helplessness. Because I suppose maybe wanting the perfect donor is an attempt to try and control, and partly to do with the loss of not having been able to use one's own, but also I suppose to reassure on the one hand that, and also to acknowledge that it is different and there is a degree of lack of control on the one hand, And then on the other hand, I suppose to know that even when one uses one's own gametes, there's no control. There's not always full control, the truth be told. And, I suppose to have realistic expectations, of when one chooses something or, and not trust it. Realistic expectations of the donor, and maybe also trusting in the nurture process of growth and development and human development, that when they do have their baby, it will be their own, and what the control they do have on the parenting process and what they do from there. So helping them to look at where they do have control. But I suppose also just the other thing to say in that is helping them also just to trust in what we're trying to do in terms of the assessment process, and what the agency is trying to do in terms of there are assessments that are happening, which might also be reassuring, that if there are significant concerns, they are being ruled out and dealt with. I suppose that's why these assessments are important and hopefully reassuring for the recipient.
Yeah. So it sounds like part of your role is to manage the expectations of the donor and the recipients, or at least support them in managing their expectations.
Yes.
Okay.
Yes.
What are the reasons for that a donor might not pass their psychological assessment?
Well, I suppose mention those are the exclusion criteria that I mentioned earlier. For those
what are the implications of not passing the assessment?
Okay. Yeah. Sorry, do you want to finish your sentence?
So could the donor go for a second opinion? Could they? Do you work with other colleagues?
Yes, I do. So I have to say that and you'll know this about me, that I never, when I'm concerned about passing the donor, and sometimes they're grey areas, thank goodness I work in a team of about 14 fertility counsellors. We are a unit. We meet regularly for supervision, for working out guidelines. We're members of SOSREG. I don't know if everyone knows what SOSREG is, should I say?
Yes.
It's the South African Society of Reproductive Medicine and Gynecological Endoscopy. And the counsellors are also a group there, and we are all members. And so thank goodness for our fantastic group of counsellors, which are, I think there are about 15 of us in the country. Okay, so not a lot, but yes. And I always, we've got a group where I always consult with somebody or a few of the other counsellors on an opinion. So there's always a second opinion. If it depends why we exclude. If it's because there's a genetically inheritable psychiatric diagnosis, that's never going to change. And therefore the donor is excluded from the process and will be excluded, will be excluded.
Can a recipient?
Can I just say, if it's because the client or the donor, is currently in a distressed state, I might recommend that in a year's time, if they're still wanting to donate, they be reassessed at that stage. Once they've gotten the support they need, once they've gotten the counselling, and I will give recommendations.
Okay. Can a recipient request a copy of their donor's report?
Not that I know of, no. From my understanding, when my assessments obviously are confidential, but my donors always fill out a consent form, which says it's confidential. However, I am allowed, they grant me permission to share that information with the clinic and the doctors and the medical professionals working at the clinic. So where recipients are able to get information about the donor, via, I think it's, the referral agency and the doctors, they can't have access to the report, but they can, I suppose, have access to the very relevant information if there's a diagnosis. And I will say, if there's anything relevant, I will often say in my report, there is a history of depression, or there's a history of dyslexia, learning difficulty, this information, while it doesn't exclude, needs to be shared with the recipient for them to make an informed decision. So the recipient would always have access to the information, not necessarily my report, but the information that's relevant.
Okay. So if a recipient, based on the information that the clinic gives the recipient, if the recipient wanted to contact you because ultimately you had the session with the donor,
Yes.
for some clarity or some understanding about whatever issues you picked up?
Yes.
Would you, and how those issues may affect the recipient's family? Are you available for a session or contact with the recipient?
Yes, of course, I would not ever disclose the details of who the person is, but the information about that person without disclosing their name.
Okay, all right, that's very helpful. So do you think it's important for a recipient to also undergo implications counselling prior to the gamete donation treatment cycle?
Are you asking, should it be, do I think it should be mandatory, or are you asking, do I think it's helpful?
Do you think it's helpful, and do you think it should be mandatory?
Yeah, such a tricky one, Matt. And I think countries around the world have got different rules around that, and different policies, should I say. And even in some countries, some leave it up to certain agencies to make it mandatory or not. There are two questions: mandatory, the pros and cons of making something mandatory, and then what I think about implications counselling for recipients. So let me start with the first. Well, let me start with do I think implication counselling for recipients is beneficial? Absolutely. I think I think that various studies have shown that counselling in this case generally, but in this case too, reduces stress, anxiety, depression, helps deal with feelings of loss, increases coping skills and strategies.
So if it was made mandatory, do you think the counsellors would have capacity to see all these recipients? I mean, considering that there are only 14 to 15 fertility counsellors in the whole country.
It's a good question. And yes and no. Maybe they'd have to develop more capacity and train more people. I mean, there've been many discussions about that. If that had to happen, there could be in-depth specific training of existing therapists and of existing counsellors, therapists, to split with the specific, knowing specifically how to facilitate implications counselling. So one could develop capacity if it had to come to that. I've no doubt there'd be interested people in our community of therapists, but it would have to be a process. It might have to be a process.
Okay.
But I don't think that would be a reason not to offer it if need be.
Yes.
There are pros and cons of it being mandatory. The ethical implications. Around patient autonomy. When things don't become, when you feel you don't have a choice. When resistance can build up, and then that impacts on how you tolerate or what you take in. Cost, time. I think fertility treatment already has
there are all those considerations to think about.
Exactly. So I don't think it's a simple one. Should it be highly recommended in every clinic? Absolutely. Absolutely. Because there also might be vulnerabilities. Now, the purpose of that kind of counselling is to offer counselling and support, losses, coming to terms with process of acceptance, feelings of depression, because in order to deal with that before going on the next step can be very helpful for the next step, for attaching to your new baby, so I do think those would be preventative measures. Also, about education to parents, when to tell, how to tell, should we tell, at what age to tell. Those are important things that I think often, people are left wondering and having to guess or do it themselves. And I do think that would be very beneficial. And also an assessment evaluation of where the couple are and where, or the person is, and, to assess timing and what support is needed.
Yes. We highly recommend counselling for all of our patients, because it, like you said, it really does. It's not just about what they have been through up until this point, but it's also important to us that a recipient or a patient is healthy going into the next step, into whether it's egg donation or IVF or another cycle. It's important that they have as much in their arsenal to face and participate in their next steps.
Yes, absolutely.
Yeah. So, Jenny, do you think one session with a donor is enough? If not, how many would you suggest and how often?
Mm-hmm. Look, what I think it needs to be kind of declared or kind of made clear, let's say, is that the 1 hour psychosocial assessment that I do, or that me and my colleagues do, it's not a full psychological assessment. It's not, it's not an all-encompassing personality assessment, or psychometric testing is not used. So it's a part of a bigger assessment where they go through the agency, the doctors assess them, so it's one part of assessing the donor. How long is a piece of string? One could maybe spend more time with some. I think it's good enough to get a general feel and to get a history, a detailed history. If there's ever a feeling that I need more information, I do, for example, if the donor has mentioned they have been in therapy or they've seen a psychiatrist or they've been in a clinic, I can always make contact, if need be, with those medical practitioners. And that's in the consent form. They've granted me permission to do that, to get relevant information. So I then get, collateral. So that's an extension of that hour.
Yeah.
I suppose one also has to be realistic in terms of time, money, but I would say it's good enough, but it also needs to be, seen as part of a bigger assessment, and also to know what it's not.
Okay. And do you think from a psychological perspective, do you think there's a difference between the temperament and motivations of egg donors and sperm donors?
Not necessarily. I think that, my assessments, my questions I ask are identical for male and sperm and egg donors. They are, I do the exact same assessment. I think where the difference comes in is that the physical treatment and medical treatment, or procedure, should I say, for men and women is different. It's more time consuming for women, it's more intrusive. It impacts, both have got their challenges along the way, but so it's more time consuming. So one might say that in terms of that, there are different implications for egg donors.
Okay.
But on the whole, I think, similar implications with them. And similar things to consider and similar needs.
Okay. Do you offer the donors psychological support during the cycle?
What I do make clear is that they need to take care of themselves, and they need to shout out and I know that you're their Lenkini and their doctors, that if they need any support, they need to reach out to their doctors. And then I know that there's a channel of communication, that then that could come back to me if need be to offer support that's required.
Okay.
But also, in part of my assessment, so if I mentioned, was about how they can take care of themselves during the treatment, what to expect from the treatment, and how to help themselves and manage themselves through that as well.
Okay. So our final question, could the process of stimulation with hormones affect the mental well-being of the egg donor?
Yeah, look, that's partly a medical question. But that is another reason, as I said, why I want to determine if there's any specific history, mental health history, because, various medications can trigger, and to work out if the donor is currently on any medication currently, just so that, which I then put in my report for the doctors to be aware of, so that there's an awareness, and if there's a donor who has experienced depression, anxiety, or any other significant issue, I do make them aware that they need to watch out, and that there could be. Often there isn't any side effects, but that it could be triggered. I always also ask about previous traumatic experiences, just in case there's anything triggering through the examination that might trigger for a donor, so that they're aware and still going in with their eyes wide open, not to say it will trigger, but it's just about creating an awareness and safety for the donor.
Okay. Any closing thoughts on the psychological screening of egg and sperm donors? Any advice?
Any advice? Yeah, I suppose I think I've said it already, but I think it's for donors to see it as an opportunity for self-reflection, for personal growth, and that it's not only about gaining information for the recipient, which it certainly is, and that's a vital part of the process, but it's also for their safety and to make sure that this is the best decision for them too. So, it's multifaceted. And that one tries to do it in the safe, in the most supportive and empathetic way.
Okay. Well, Jenny, thank you so much for your time and your insights into the psychological screening of our donors. I'm sure this has been very helpful for everyone, and we've all learned a lot from you. Thanks to everyone for joining us. We will have Jenny's contact details at the end of this video, so you can get in contact with her. You can also contact us or contact her through our clinic. Thanks for joining us on this episode of the Fertility Diaries. Our next Q&A will be with Andrew Martin on IUI and IVF donor consent forms, so that should be interesting. You're most welcome to send us questions in the meantime. Thanks everyone, and enjoy your weekend.